Hi everyone. This week our topic is contraception. So we'll start by just having a brief overview of some of the statistics around unplanned pregnancies in the United States, and then we'll talk about things to consider when choosing a method, and then we'll get into some of the details regarding non-hormonal contraceptive methods and then hormonal contraceptive methods. So to start out, it's about half of pregnancies in the U.S. are actually unintended. So that doesn't mean that they're unwanted, but they weren't planned. And having unplanned pregnancies can have negative consequences with the women that we work with. That can include depression, increased risk of physical violence, and then delays or even lack of prenatal care, which can definitely affect birth outcomes as well. So in 2006, unintended pregnancies cost the general public about $11 billion. So it affects society in a variety of ways. Thinking about trends, so looking at 1995 up until around 2010, sterilization has remained a fairly popular option for women, still not very many men buying into it. The pill is still really popular. Condom use has gone down a little bit, but still pretty common. And then other hormonal methods like the patch and the ring have been increasing, partially just due to their availability within the last few years. And then IUD use has gone up significantly as well, but in the grand scheme of things is still not a particularly popular option. So what are women looking for in a birth control method? This is always the place our visit starts. So it could be that they want to make sure that it's really, really effective. That's the most important piece. Or maybe that's not the most important piece for them. It might be convenience, something they're not having to think about every time, like a condom, versus an IUD, where once it's in, they just don't have to think about it and there's nothing they need to remember. It could be not having to think about something that would spoil the mood when they're having sex, or maybe they're wanting more consistent periods, some of the benefits that can come from being on hormones. Maybe they're desiring no hormones. They might be particularly looking for a method that doesn't involve any pain or doesn't feel invasive, like having an implant put in or an IUD put in. And then maybe what they're looking for is short-term or long-term. That's something I always want to ask too when you're thinking about reproductive life plans. When are you thinking you might want to start trying for another baby? So let's go through the difference between efficacy and effectiveness. Basically, efficacy is how well a method will work inherently, whereas when we're talking about effectiveness, it's how well a method works in actual practice. So we think about the difference between perfect use and typical use. So if I say that you need to make sure when you're taking the pill it's at the same time every day, perfect use, this is how effective the pill would be, versus typical use for your typical mom who's using the pill. How often does she skip a pill or take it at an inconvenient time, etc. Typically that typical use is going to be more meaningful for us in practice than what the perfect use is. So when we're thinking about the grand scheme of methods, you can think about condoms and the withdrawal method, spermicides, natural family planning in general as being less effective. So we have about 18 more pregnancies per 100 women in a year. So typically we're going to think about contraception within the context of, if a woman used this method for a full year, how many women out of 100 would get pregnant in that year. So we're talking 12 cycles roughly, and then that's how it's calculated. So 18-ish% would get pregnant if they were using this method. And then in the middle we've got our combined hormonal contraceptive options like the pill, patch, ring, and then you also have injectables here, and the diaphragm even gets bumped up into this section. And then you, at the very top, would have implants, vasectomies, female sterilization, and IUDs as being the most effective, with less than one pregnancy per 100 women who chose this method for the year. So for any of these categories, there are ways to make the methods more effective. So for vasectomies, for example, you need to not have sex for the first 3 months or use another method for the first 3 months, because there can still be sperm on the other side of the vas deferens from where it was clipped. Or with injections, needing to make sure that you're getting your repeat injections on time, pills you're taking them every day, basically that you're using whatever the method is, however it's supposed to be used, and that's going to increase the effectiveness and get you closer to that perfect use. So this graph should look very familiar by now, but just so we're all fresh and remembering how the normal cycle would work, we have our egg that's slowly growing in its follicle throughout the first half of the month. So this would be the follicular phase, and then ovulation, followed by the luteal phase. And we know that that egg, so these would be the hormones that are regulating that process, right? But we'll just look at the bottom half of this for thinking about our cycle. So that developing follicle is releasing estrogens. So that's our dominant hormone for the first half of our cycle. So we call that the proliferative phase, when our endometrium is building up its lining, the very beginning being the shed, but then estrogen's building up the lining, and then we have our ovulation period, at which time we still have estrogen here, but then progesterone becomes much more dominant because that's being released by the corpus luteum. So we have progesterone as our dominant cycle here. And then other things we're thinking about are like our cervical mucus, how that's affected. So we know that it starts out kind of absent to thick and tacky, and then it starts to get more stretchy in this region here, and then it gets clearer and really stretchy here to pull sperm up into the uterus. And then shortly after that 24-hour window when the egg is no longer viable, our cervical mucus gets back to being thick and tacky or absent again for the rest of the cycle. So we're keeping this in the back of our minds for all of this, regardless of what method we're using. And then understanding that if we are choosing a hormonal method, if it has both estrogen and progesterone in it, basically the goal is to get us somewhere in this zone and keep us there, where our cervical mucus is constantly thick and tacky, and where we have enough estrogen and progesterone that it's sending a message to the brain, like it is in this territory, to say, don't release FSH, don't release LH, it's not time to make an egg, we might have a pregnancy. We're just kind of keeping the body frozen in this state. So both the estrogen and progesterone, we have progesterone that's primarily sending that message to the brain not to release FSH and LH. Estrogen's doing the same thing to a smaller degree, but then estrogen is helping maintain that normal cycle of growing a layer and shedding a layer once they're on like the placebo pill week, for example. Okay, so we have that in the background of our minds. So we'll start with fertility awareness methods or natural family planning. Basically, this is about understanding your cycle well enough that you can either use a backup method when you're particularly fertile, or else avoid intercourse during those time periods. So based on what aspects of natural family planning you're using and how good you are at adhering to them, failure rate is anywhere from 1% to 25%. So it can be acceptable for cultural or religious reasons where other options might not be available, so that's something to keep in mind. It's also non-hormonal, which makes it popular, especially among particular midwife patients. But in general, you do need to have regular menstrual cycles. It can restrict sexual spontaneity, especially if it is an abstinence period versus using a backup method like condoms. And then it really does require ongoing effort and commitment, and that's by both members of the relationship. If you have a dad who's not on board, it's going to be a lot harder to maintain it. So different ways to do natural family planning. One would be the calendar method. So basically to do this, a woman would want to record her menstrual cycles on a calendar for 6 to 12 cycles, so she has a really good idea of what her normal is. And in order for this to work well, she needs to have cycles that range between 27 and 32 days. And then what she would do is she'd take out of that 6 to 12 cycle set of data that she's collected, she'd take the earliest day of a fertile period, so say her shortest cycle length for that entire year that she collected data was 28 days, she'd go 28 minus 18, and that would get her to 10. So her earliest day of her fertile period would be regarded as day 10. And then for that final day of her fertile period, she'd take her longest cycle. So say her longest cycle was 31 days. So all her periods were 28 to 31 days. She'd take that longest cycle, 31, and then go minus 11. So then that would mean 20, right? So then from days 10 to 20, those would be the non-safe days for her. And so the calendar method, usually what trips people up, if that's what they're using it, is they have that one random month where they throw an early ovulation or something like that. So if you're going to use the calendar method, you really need to have regular cycles. Oftentimes if people decide to do a calendar method, they're going to layer their calendar method on top of another type of method. So another one would be the standard days method. This one works somewhat similarly. You can get these cycle beads pretty easily. So this is ideal for women with menstrual cycles that are somewhere in the 26 to 32 day long range. So what they do is the first day of their period, they move this little rubber ring over the red dot, and that signifies day 1. And then every day they move it over another bead, another bead, another bead, and then when they get to the white beads, that's when pregnancy would be most likely to happen. So those would be the days where they use condoms or are abstinent. So then once they get to the end of the white beads here, then they would know that it would be safe to not use condoms again. And then if you get less than this dark bead, then that's a signal to you that your cycles are lasting less than 26 days, making this whole concept not as effective for you. So you want to see that your cycle's getting past this little dark bead, and then somewhere in here is when we're expecting you to get your period again. And then, so if they're here when they go to get their period, then they skip over here and start with day 1 again. So as long as their cycles are ending in this zone, then they can feel fairly confident that it's still a good idea to continue to use this method. I see this used a fair bit overseas as a great way for women to keep track of their cycles in some underdeveloped areas. So then we have our cervical mucus method, and this would involve consistently charting your mucus every day. And I know women who have used this for a long time, and they might have started out meticulously charting it, but over time they get used to just checking every time they go to the bathroom when they're wiping to see if they have the spin market mucus. And it's just part of their daily routine, and they're not necessarily meticulous about charting it. So this is probably already fairly familiar since last semester, but the general thought would be that non-safe days would be 2 or 3 days before the first signs of the slipperier mucus, kind of that semi-fertile mucus. And then you would continue to abstain from sex for 3 days after noticing the particularly fertile mucus. So once that's stopped. A simpler version of this would be the 2-day method, which basically involves saying, did I have cervical mucus today? And did I have cervical mucus yesterday? And if the answer is no to both those questions, then it's safe to have intercourse. So some women, you can really notice cervical mucus regardless of where they're at in their cycle, so that would be harder for them, versus a lot of women will just have more of that spring market mucus show up, and then the rest of the time, more the thick and tacky to absent, it's more on the end of absent, if you will. So for women who just tend to have a lot of cervical mucus, this can be a trickier method for them. And I love the Creighton model. They've done a lot of research around what they do, and it's not exactly the 2-day method, but it basically follows in line with that. The Creighton model, they will use counselors to train women into doing this for themselves, and it involves a big spreadsheet with stickers and all that kind of thing for them to track their cycles really closely, and then they can meet with counselors to go over it. And I've seen this used both for natural family planning as well as for trying to get pregnant. And then they'll use it for a lot of different menstrual disorders. And there's kind of 2 levels of counselors. One would be for people who are looking to understand their cycle better to, say, avoid pregnancy. And the other one would be providers who go through advanced training in order to use the charts that these women are bringing in to really work with them closely on issues like fertility. They very much, it's Catholic based, and they very much stand behind abstinence on the off days. So I give women a heads up on that if they're thinking they'll probably use condoms or whatnot for their days when it's possible to get pregnant. But oftentimes insurance companies will cover the counseling training around this. The other benefit to using this method is it works for breastfeeding moms when they don't have their periods back yet, or when they're starting to have their period again, but it's still really inconsistent. This method still works. So the cervical mucus method is still applying even if we don't quite know what our normal cycle is just yet postpartum. And then basal body temperatures could get added to this as well. I think you guys are already fairly familiar with this, but this is where we're thinking about in the proliferative phase, we're pretty low here, or the follicular phase if you're thinking more about ovaries, whereas once we pop up here to the luteal phase, we see that jump in temperature. So they need a basal body temperature or thermometer, which is really cheap. Like at Walgreens, you'll get it for less than $10, but it'll add an extra point to the end. Like it'll be 98.68 or whatever, so that it you have an extra decimal point at the end there. So this is good for understanding how your cycle works, but then obviously if you see the jump, then you've already ovulated, so it more tells you after the fact if you shouldn't have had sex, rather than giving you a heads up if it's okay to have sex. But this can be part of just that overall gaining a good understanding of how your body works and when you tend to ovulate, that kind of thing. And helpful for trying to get pregnant as well. I think this, if you're going to use this, you would use it in combination with another method. You wouldn't typically have this be your only form of natural family planning. And then we have the withdrawal method. Failure rate ranges from 4 to 27%. Again, no hormones, readily available, so that's convenient. And then obviously you need a man with good self-control who's also able to tell if he's going to emit soon, and then needing that consistency of using it every time. So, and with all of these methods so far, they wouldn't protect against sexually transmitted infections. So lactational amenorrhea, 98 to 99% effective if we're talking the first 6 months. It prevents ovulation. So we know 3 things need to be in place in order for that to work. So they're not going more than 5 hours without feeding. So if babies are sleeping through the whole night, you get 7 hours of sleep, then all bets are off. They need to only be breastfeeding. So it'd be fine if they were bottling with express breast milk, as long as mom's at least pumping every 5 hours, right? But if formula is introduced, or if at 5 months they start doing Cheerios, then all bets are off again. And then if she's gotten her period, again, all bets are off. Okay, then we have male condoms, basically talking about having a barrier method. Obviously, this will reduce our risk for STIs, so that's a big plus. Failure rate ranges from 2 to 18%, so based on that typical use piece. Cost effective, generally widely available, making sure that they're storing them in a cool, dry place. And a fair bit of counseling can go around condoms, so don't be afraid to state the obvious if you're counseling women who are planning to use condoms, especially if you're working with a younger population. And then female condoms, for the most part, have run out of popularity, but this whole ring here would go up into her vagina, and then this part would be outside of her introitus. So then, in order for it to be effective, you need to make sure that the penis was going inside the wider ring, which this is a thing that can actually be a problem. So making sure they realize that it needs to go inside the ring. It's a nice option if you're working with women who don't necessarily have a whole lot of control in their current situations for what is used. This is a way for her to be able to protect herself. Alright, and I still see them in the drugstores. So, I rarely hear somebody say that that's what they're primarily using, but I do see them around, so some people must be using them. Okay, and then we have diaphragms, which are dome-shaped cups. Silicone failure rate ranges somewhere between 6 and 16%. You insert it into the vagina, and it covers basically over the cervix, but it's more like the bottom rim is up under, it gets underneath her cervix, and then the top rim is like just behind her pubic bone. So it's kind of like it essentially runs across the whole top of her vagina, but then still tucks underneath her cervix. So the penis would be like on the posterior surface of her vagina, or posterior region. And every time she uses it, she'll put spermicide all across the rim and then a dauble in the center of the diaphragm tube before putting it in. So she can insert it for up to 6 hours before intercourse, which is nice. So then, if they don't want to mess with condoms in the moment, she can put it in before dinner or what have you. And then she should leave it in place between 6 and 24 hours afterwards. So basically just say you can sleep with it and then take it out in the morning. And then if she was going to have sex again in that time period, she doesn't need to take it out and add more spermicide, but she should add more spermicide in before having sex again. So she shouldn't remove it, but she should add more spermicide if they're going to have sex multiple times. And the fitting really is not very hard. I might be the only one in Minneapolis who's fitting diaphragms right now, so I don't know if any of you will have the opportunity to fit for diaphragms. But I think I heard that Health East is still doing cervical caps, which are basically, it's a pretty similar concept, but it just needs to tuck right up over the cervix. And isn't as effective as diaphragms in that it's hard for some women to find their cervix. So good luck with that discussion with your moms. And then basically the only downside, and I haven't had this issue, but it can increase women's risk for UTIs or chronic yeast infections, or not necessarily chronic, but just yeast infections, bacterial vaginosis, just introducing different things into her flora. And then it is possible to get green spermicide, if you will, on the internet rather than having spermicide. The typical spermicide you get over the counter tends to break down tissues more easily, and thus can increase your risk for acquiring sexually transmitted infections and that kind of thing, and disturbing the flora. So just something else to keep in mind. Okay, so we just went from basically the lower level of the ladder all the way to the top now. So Essure would be in that top bracket for being highly effective. Basically, you're thinking of this as an alternative to female sterilization with getting like her tubes tied. So what Essure is it's this tiny thin little coil of wire, and the provider, I haven't heard of any midwives who've been trained to do this, so typically you'd be referring out for this. But what the provider does is they put a hysteroscope through the cervix, and then, I didn't mean to click here, through the cervix, and then they would put the spiral tube in the fallopian tube here. And then over the next 3 months, scar tissue would continue to grow through this fallopian tube. They'd be doing it bilaterally. So it would continue to grow through the fallopian tube, and then they would go back to that office and have a hysterosalpingogram where a dye is injected here, and then you would look to see if the dye would show up on imaging, and we're assuming that if the full scar tissue is here, then the dye is going to stop here and not be able to get up through the fallopian tubes. So if they have it done, then they need to still use the backup method for 3 months before assuming that it's good to go. It can offer some advantages over sterilization. The procedure in general is a lot safer, and it doesn't require any incisions. So general anesthesia isn't needed, and you don't need a surgical setting, so it's pretty easy to do outpatient. Recovery is pretty fast, and some women will just return to their normal activities that same day. So it's a nice alternative to sterilization. So sterilization, a couple different ways to do it. Sometimes it's cauterized versus tied and cut. versus banded. So that would have the potential for opening that band and having patency again. So a lot of times it'll depend on the surgeon for what options women would have there. Typically it'll be laparoscopic these days, but it could just be a little mini laparotomy as well. Risks would be just general surgery risks, thinking about infection, bleeding, reaction to anesthesia, ectopic pregnancies, to name a few. And that would, generally speaking, be very permanent. Vasectomy is a little bit less invasive than doing female sterilization, but basically we're just cutting the vas deferens here. So we know our sperm is made here, then goes up through here, and since most of our actual semen is made beyond that point, they would still have an emission, but the emission wouldn't contain sperm. So something to think about with this procedure is that we can still have sperm located at the rest of those tubes. So we would need to wait at least 3 months, and then typically they'd go back into the clinic and make sure they could do a semen analysis and make sure that there isn't any semen still located, or sperm still located in the semen. And then, so again, that's a backup method for 3 months. It's a lot less complicated and less expensive than female sterilization, so I wouldn't mind seeing the vasectomy versus female sterilization pick up a bit moving forward, but the Essure is a great option as well. So that basically wraps it up for our natural methods, except for the Paragard IUD, which is copper, or non-hormonal, I should say. So of our non-hormonal methods, the only one still to come is the copper IUD, which I plan to talk about when we talk about the hormonal IUDs at the end. So we're switching gears here from our non-hormonal methods to our hormonal methods, and we'll start with combined hormonal contraceptives. So combined means both estrogen and progesterone, as opposed to progesterone-only methods. So we know that progesterone is essentially our birth control, because it's telling the brain, don't release an egg, don't make an egg, don't release an egg. Whereas our estrogen is playing a heavier role in our cycle control, so having us build up an endometrial lining and then shed it each month, so having that consistent, regular cycle control. So for combined hormonal contraceptives, there's 3 options. There's pills, there's the ring, and there's the patch. And what I want to say right from the get-go is regardless of which one of these 3 a woman is taking, she has about the same level of hormone in her blood. So it's a common misconception that like the vaginal ring would just be local hormone in the area of the vagina that's working on the ovaries or whatnot, just locally, but really it's the same amount of hormone essentially in the blood as if they were taking it by mouth. So if a woman was wanting to avoid some of the side effects that are associated with pills, primarily like the side effects that are more GI related, then they might be able to offset some of that by using a vaginal ring. But otherwise, all the other side effects, anytime we're talking about side effects associated with combined hormonal contraceptives, it would apply to any of these 3 methods. So primarily it's working by going to the brain and telling the brain not to release FSH, not to release LH, so we're not even growing and releasing an egg. So that's the main way it's working, because that's what happens in that frozen state of the cycle, right? So more that luteal phase where there's both estrogen and progesterone present, which means not only is it in a phase where a follicle isn't growing and getting ready to be released, but it's also in a phase that has cervical mucus that would make it hard for sperm to get up into the uterus and get to the ovaries. And our endometrial lining would also be thinner because I guess I think of it as kind of the tail end of the luteal phase. So our endometrial lining is thinner, so if there was a fertilized egg, it would be harder to implant. And then it also slows down motility, so thinking about the cilia that are in the fallopian tubes. So all of these things are happening to make it hard for a sperm to meet an egg, hard for an egg to be there in the first place, and then if there was a fertilized egg, hard for that fertilized egg to implant. And again, that primary method being preventing ovulation in the first place. And just thinking about as far as the endometrial lining goes, estrogen is working to build up a lining, whereas progesterone is thinning that lining. So to have both of them on that board just kind of keeps your endometrial lining at a constant thinner level. And then when they do go off of the pill briefly, or take out their NuvaRing, or take off their patch, to have the hormones drop like that means that the thin lining that they did have would shed. So you don't end up building up that thick of a lining if you're on the pill. And that's always important. Anytime you give estrogen, you're always giving progesterone too, or there would be a risk of, say, uterine cancer from having uncontrolled endometrial growth. So you have estrogen that's causing the lining to grow up, and progesterone that's causing it to actually stay thinner. So they balance each other out that way. So how do pills come? Let's talk about pills. So the first thing to think about would be phasic. Phasic, so it could be monophasic, meaning so you have active cycle pills, and then you have placebo pills, right? So for the active cycle pills, is it the same level of estrogen and progesterone every day, followed by the placebo, or is it biphasic, meaning that for the first half of the month you have a certain ratio of estrogen to progesterone, and then the second half it's a little bit different, or triphasic or quadriphasic? So all of those exist. Most of them are monophasic. So typically how that would work then is you'd have 21 to 24 days of an active pill, which would be both estrogen and progesterone, followed by the medication-free interval, which would be about 4 to 7 days. So things to think about here: the more phases there are, the trickier it gets. So they open up their pack of pills and there's more colors. So in general, I think the simpler we can keep it for women, the better. COCs, or combined oral contraceptives, they started out by having triphasic pills, and then slowly we've moved away from that into primarily just doing monophasic pills. There really isn't a whole lot of a reason to be doing them in more than a monophasic pill. Some research suggests that we might have decreased numbers of total bleeding if we will do a biphasic or a triphasic. Some women really like the idea of them cycling, of having kind of a cycle of different levels of hormone throughout the month. So that's kind of the whole reason we're doing the pill, is so that we're not cycling the way we would usually cycle. So a little bit of a back and forth there, but if you do have a woman who's wanting to cycle for whatever reason, that would be something to consider. Or, I mean, I think that would be an interesting research study to take a look at some of the differences in bleeding patterns or whatnot between them. But typically you're picking a pill, unless she's seeking it. I think it's easier to just go with monophasic pills. But you might find your preceptors or yourself down the road might have different preferences that way. And I just want to give this a blanket statement. A lot of people talk about the pill as if there's just one pill, and you've probably already figured out there's like a million pills. And I think that can be kind of overwhelming as a new prescriber, like what am I supposed to do here? And there are basic principles that would pretty much work for most everybody. I think most providers I know tend to have one or two pills that they tend to just kind of give to everybody coming in that they're comfortable with and used to. And then if women are having issues coming in or having issues with side effects, thinking about looking into a different type of a pill. But there is such a thing as having a couple that you're used to using and not having to feel overwhelmed by just how many options there are for you to be prescribing. So I should have just said that right up front. So first you're thinking, are we going to do a monophasic, or are we going to choose a different way to do it? So we've decided we're going to do a monophasic, and then your next option is if we're going to do this typical cycle where they have their 21 to 24 days of active pill followed by the medication-free weeks, or if we're going to do extended or continuous cycling. So extended would be typically like having 84 days of active pill followed by 7 days of having a period. So there'd be more days of bleeding. Typically with this, people tend to have a little bit more spotting in the meantime because at some point you have enough of a lining that it wants to shed and it isn't quite getting a chance to, so you might have a little bit of breakthrough bleeding. And just in general, they would also have some more exposure to hormone the longer they're by taking it this way to do extended. But there are some benefits. If you have a woman with really bad, say, menstrual migraines that are very linked with her periods, this is assuming there isn't any aura or concern on that end, or like say she gets really bad cramps and has to take 2-3 days off of work every month because her cramps are so bad, this would be a reason to think about doing an extended cycling where she just doesn't even have to mess with her period. Or maybe somebody has really bad PMS symptoms. If we can downplay the effect that the period has in just the shift in their hormones by skipping it, then that can really help with some other symptoms in her life. And you could do this with other methods too, like the ring is designed to, you put it in for 3 weeks, and then you take it out for a week, and then you put in a new ring, put that one in for 3 weeks, and then you take it out for a week. You could just keep it in for 4 weeks, take it out, put a new one in. So it's okay for you to be a little bit creative this way once you kind of understand the principles behind it. You could take any of these methods and turn it into extended. But there are some that are meant to be extended, so it's not like they're having to quickly go from one pack to the next and skip 7 days from one pack to the next, and then it gets tricky with them trying to renew their prescription or what have you. So just something to think about. And then there would also be the option of just taking it continuously, where for 364 days in the year, they just take an active pill every day. So that would be an option as well. And then just to touch on those placebo days, you'll also see some differences where some packs will have iron during those placebo days. So just thinking about how a woman is bleeding during that time, it's automatically replacing some of that for her. Others really are just true empty pills, the sugar pills, if you will. And then, so we started out having it where estrogen levels would be 35 micrograms or higher. But then when we started to move into doing lower dose estrogen birth control pills to say 20 micrograms, that's where it started becoming an option to have a shorter period. That to go a full 7 days, they really would start to build up a follicle again. So it's typically those higher dose estrogen pills that will have a full week of placebo, whereas if it's a lower dose estrogen pill, then there's not as many days of a placebo. I kind of tend to lean towards picking options where I think the fewer placebo days, then the less likely people get off track. And encouraging people to still take their placebos, I think, is good, just so that they don't lose their routine. Because oral contraceptive pills are pretty effective, but the typical use is not nearly so good as the perfect use. So people missing pills is a big deal. Okay, so now let's move on to talking a little bit more about the hormone ratios here. So generally speaking, estrogen to progesterone in pills is somewhere in the 1:10 to 1:30 realm. And in a normal menstrual cycle, if it's in the proliferative phase, so the first half of their cycle, it'd be about a 1:10 ratio of estrogen to progesterone. And then just before ovulation, it's more like a 1:5, so that estrogen kicks up a bit. And then the ratio in the luteal phase is more like 1:50. So just to kind of have that in the back of your mind as a reference for how a normal menstrual cycle would function in comparison to the pill. So then pills have estrogen and progesterone. Estrogen is almost always going to be ethinyl estradiol. So that is basically what estrogen you're going to find in every pill. So then the only choice to make then is if you're going to do a lower dose, so like a 20 microgram, 30 to 35 or more middle of the road, and then 50 would be intentionally being a higher dose of estrogen. So that's one decision. And then just to realize progesterone comes in a million different forms. So I just listed a little handful of them here so that you could kind of get used to what they sound like so you'll recognize them. Actually, progestin would be a better word here. So progesterone is what the body makes. Progestin is a synthetic form of progesterone. So all of our pills would have progestin in it. And the form of progestin could be norethindrone or it could be desogestrel. So usually they end in ones or estrals. So that's kind of your clue to knowing that that's your form of progesterone that's being used. So like the Mirena IUD, that's levonorgestrel, for example. Again, we're not trying to get overwhelmed with all the options. So I'm going to give you your general principle now. So general principle when you're picking is that you want the lowest dose possible that's going to work well for this woman. So starting with a lower estrogen level and starting with a lower progesterone level, that's basically the key. So we're starting, with a 30 or 35 at the highest, maybe 20 micrograms is a good place to start. So, and then if that's assuming we don't have any kind of history factors that she's coming with us that would make us think about starting from a different place. So we're picking a lower dose estrogen, and in general picking fewer days of placebo pills, I think is good as well. And then also keeping in mind insurance coverage, because sometimes you pick one and then she calls you and says, my insurance doesn't cover this one, or it's really expensive, and then I think talking to the providers in your clinic and they can give you kind of the lowdown for what good options are in your area, and then some of it just does come down to people's individual insurances. And your pharmacist can be good resources for that as well. I know several times they've given me a call and said, hey, I have so-and-so with me right now. This is what you initially prescribed. I see that this other option that we have here would be significantly cheaper and is basically the same thing as far as estrogen to progesterone ratio and types that are being used. Would that be an okay substitute for what's going on with this gal? So all of that would be things you can consider. Okay, this page is gold. Pay attention to this page. I think you already know a lot of it, but really let this sink in, because this is what's going to help guide you when you're thinking about managing side effects and when you're thinking about certain people walking in and perhaps being a better candidate to start kind of from a different baseline than what you usually would with picking a lower estrogen to start out or what have you. So, so basically, combined oral contraceptives or the NuvaRing and the patch are going to do 5 different things in the body. One will be estrogenic activity. So that's going to include nausea, endometrial growth, heavy menstruation, severe cramps, fibrocystic breasts, breast tenderness. So having a pill with a lot more estrogen in it is going to end up swinging you more towards these kinds of side effects. But also you might have a woman come in who already has a lot of these complaints, in which case you're really intentionally picking a birth control pill with a lower estrogenic activity to it. So then the next step would be progestational activity. So this includes a lot of your more PMS symptoms. So edema, bloating, headache, depression, decreased libido would be in there, weight gain, increased appetite. Those two things are completely linked. And I think telling people that can help offset it sometimes. Knowing that progesterone will increase your appetite can help them know where the weight gain is coming from and try to curb it appropriately. Fatigue, high blood pressure, varicose veins, these are more related to progesterone. Also, in terms of thinking about a woman's symptoms coming in before she even starts a pill, if you had a woman come in who was having irregular bleeding and spotting, that would be more of a sign of having a higher progestational activity leaning as far as the woman goes. So thinking about picking a birth control pill that's lower on the progestational activity end of the spectrum. Next up would be androgenic activity. So this would be coming from your progesterones. So some of the progestins have a high androgenic activity profile, whereas others don't at all. So for example, you have a woman who's on a birth control pill and then she started to break out or have oilier skin, that kind of thing. You could switch her to a pill where the progestin in it had a very low androgenic activity profile. Most birth control pills are naturally geared towards clearing people up, but sometimes not. You can also see increased libido is on the spectrum too. So if women come in and say, since being on the pill, I feel like I've had no libido at all, you can look through your birth control options and see that some of them have a much higher androgenic activity profile, and then you could think about switching. And then endometrial activity, this is where we think about spotting, breakthrough bleeding, early withdrawal bleeding. It's going to have the greatest effect in the first 3 months. For any of this, really, that the first month especially, but really those first 3 months when you start a pill, people are going to probably have side effects, and just really encouraging them to stick it out till their body can adjust. We're expecting there to be some differences in those first 3 months. So if a woman calls and says, hey, I'm spotting, I'm a month into having this new birth control, I think I want to switch to a new birth control. If you switch her to a different combined oral contraceptive, probably she's going to just be spotting again with that one because she's needing to readjust again to a new one. So really sticking it out the first 3 months before thinking about stopping or switching is a good guideline, and the more women are anticipating that, the easier it is to kind of have them on board and know what they're signing themselves up for, which could affect what they want to sign themselves up for in the first place. So this just kind of comes with the territory of starting OCPs or COCs. So OCP is oral contraceptive pill. COC is combined oral contraceptive. They mean the same thing. I'll also see just OCs, so oral contraceptives. So you'll see any of those. And then the last thing would be effect on serum lipoproteins. Oh, which maybe I didn't mention earlier. Androgenic activity can be basically androgens are going to directly antagonize the effects of estrogen. So estrogen is building up the endometrium. Androgens are thinning it back down again. And they do the same thing with lipids. So basically, you want a higher estrogen to progesterone ratio when it comes to lipoproteins. And that would be helpful in increasing a woman's HDLs and decreasing her LDLs, so giving her a better cholesterol profile. So especially if you have a woman who's starting to get up there in years, or if she's a smoker, this would be something just to be particularly cognizant of what that lipoprotein situation is at as far as the ratio of what you're giving her. So basically, understanding this list well helps you in 2 ways. First of all, if a woman comes in with any of these symptoms as her baseline, you're choosing your pill accordingly to kind of offset it. So if she's coming in with acne and oily skin, you're wanting to pick a method that's lower for androgenic activity. If she's coming in with really decreased libido and she's depressed and is having a lot of PMS symptoms and is bloating, you're trying to pick a method that has a low progestational activity, etc. And then the other side to that would be if she's getting these symptoms from a combined oral contraceptive, then you can look at this to understand how you need to readjust her pill. And then how you're going to do that is that Managing Contraceptive Pill Patients book. In the middle of there's tables, and I think I actually have the edition that's one less than you guys. For me, it's table 9. But if you open to the middle of the book, these tables are fantastic, and you need to start highlighting and dog-earing, because this is like a Bible for you in clinic when it comes to pills. But like for me, if I'm looking at table 9, it lists different birth control pills in lumps. So it'll say, like for the group 2, that's Mercet, Natasia, and Desigen. Those would be the 3 birth controls in that category. And then for activity, it says endometrial activity here is intermediate, progestational is high, and androgenic is low. Okay, great. That's the profile I'm wanting to give her, so I'm going to pick one of those 3 meds. Something to keep in mind is the book is, I think, international. Every once in a while, I've looked at this list and I've thought, ooh, this profile for this particular drug looks perfect. And then I call it in and it doesn't exist. So for the most part, this works well, but just be ready for a little bit of flexibility. And it is crazy what they're coming out with these days. There's even chewable birth control on the market. So you don't have to say no to this if you're a woman who doesn't like to swallow pills even, or are too young to like swallowing pills or what have you. I shouldn't say that. I don't like swallowing pills and I'm not 14. Okay, moving right along. So talking about combined contraceptives again, generally a 92 to 99% effectiveness. Therapeutic uses, you can think about giving them for people with painful periods, called dysmenorrhea, or metrorrhagia, which would be irregular periods. As long as we're on that list of listing them, you could also have menometrorrhagia, which would be heavy irregular periods. So the meno would be like heavy, and the metro is the irregular piece. Oh, I spelled that wrong. No, I didn't. I don't think I did. Okay. A woman with iron deficiency anemia, especially if she also has heavy periods, that would be something to think about. Acne, PCOS, menstrual migraines without aura. So you don't just give COCs for birth control. Okay, and then warning signs, things we want to think about for all women. About 2 to 4 more women out of 10,000 women may experience a non-fatal clot that's directly related to COCs. So we do know that women on COCs are at an increased risk, slightly, for developing a clot. So part of our counseling around it is letting them know what that might look like. So this acronym ACHES lines up with that. So whether that's a heart attack or a stroke or a DVT, that can be part of your counseling. Okay, and then for common side effects, thinking about irregular bleeding or spotting, which as much as they're willing to stick with it for 3 to 6 months, ideally that'll improve. That can be due to 2 things. It could be due to having too much estrogen, as in their cycle is building up to too high of an extent, right? And then we leak a little bit past that point. Or it could even be due to too low of estrogen, as in if you think of that whole endometrial area as kind of like, as the estrogen is causing endometrial growth, it's kind of like, I picture like cotton sticking to all of the inside of the endometrium. As the endometrium's growing, it's like more little bits and little bits of cotton. But if there's not a lot of estrogen, then there might be a little gap of cotton. Cotton is, I don't know why this is my mental image here. But say we're not completely fluffing up the endometrium all the way around due to having lower estrogen, then it's kind of like it's a little hole patch where blood can leak out. So you can have some irregular spotting because you're not able to thoroughly fluff up the lining all the way around. So blood can be kind of leaking out, if that makes sense. So multiple causes for spotting. If you had a high pill, think about lowering the estrogen dose. If you had a low pill, think about increasing the estrogen dose, etc. I see the latter more often. And then nausea, more due to estrogen, sometimes just taking it at night so that they will be asleep when they would be nauseous, and then by the time they wake up the levels are lower. Breast tenderness, weight gain, mood changes. That can mean I'm really emotional, or that can mean I feel flat. Libido changes, I think, kind of go along with that as well. That can be both progesterone as well as androgenic activity, either one of those. Headaches. So most people don't tend to have very many side effects, but those are ones I tend to see more commonly. And then prescribing precautions, especially thinking about anything that's going to increase your risk for blood clots, right? So heart disease, that kind of thing. And then cigarette smoking in women 35 and older. If you have a woman who's smoking, the more you can get away from estrogen, the better anyway. But especially if she hits 35, it's time to really start brainstorming a different option. Postpartum and lactation. You'll do a lot of this in your projects for this week, so I won't belabor it, but basically realizing that people are at an increased risk for clotting in a postpartum period, with the estrogen being primarily responsible in pregnancy and then the immediate postpartum period. And then estrogen also dips your milk supply. So after you're out of that immediate postpartum realm, it would be okay to start up on estrogen again. But then if she's breastfeeding, generally speaking, we would just stick with progestin-only methods until she's basically done breastfeeding. Or until it's so well established that we're okay with messing with it a little bit. So maybe a year or two out, for example. Unexplained vaginal bleeding. Let's not mess with her cycle until we figure out why she's bleeding irregularly. So like if she had endometrial cancer and we didn't realize it and then started COCs, then we're masking whatever's going on, right? Anything that might interfere with her ability to digest an oral contraceptive pill, so malabsorption, bowel disorders, that kind of thing would be something to be cognizant of. And then also being aware of any medications that can interfere with their effectiveness. Okay, so the pill, basically 3 different options for when to start. Obviously the first day of the pill correlates with day 1, so if she really wants to start on day 1 for her pill, she's welcome to do that, though I don't know what she's been using up to the point where I prescribed it, but probably would be better to just have her start that day. Might mess with her cycle a little bit, but just for improving efficacy, being able to start up right away would be preferable. So in which case you would want to use a backup method for 7 days, since we don't know where she is in her cycle when we're starting the pill. Also the option to start on a Sunday, which would correlate with not ever having your period on the weekend. So if that sounds particularly appealing to her, that would be an option as well. And again, using backup. If it's day 1 of her cycle, she wouldn't need to use backup. Making sure you're stressing the importance of taking the pill at the same time every day. That's important with combined hormonal contraceptive. It's vital if you have progesterone-only pills. That's a must, but it's still important with the pill. If she forgets to take a pill, just have her take the next pill ASAP and continue the next pill as usual. Whereas if she's missed 2 or more pills, do that, but then plan to use the backup method for 7 days. And then breakthrough bleeding, if it's within the first 3 months, encourage her to keep going. After 3 months, try a different pill. Think about maybe changing your estrogen dosing. Okay, so moving on to the patch and the ring, which are, for all our side effects and everything, we're remembering this is basically the same as if we were on the pill. So the way the patch works is they would put a patch on their skin, so typically like lower back or upper arm, basically a place that's not particularly hairy or oily. Can be basically anywhere, and then they would wear it weekly for 3 weeks. So they put it on, maybe they put it on Sundays. They put it on Sunday, next Sunday they take it off, put another one on. Next Sunday take it off, put another one on. So they change it every week for 3 weeks, and then they take it off and go without for a week, and that's when they would have their period. And then it's fine for them to swim and bathe and do all those kinds of activities, and they just need to make sure that their patch is well adhered. So if it starts to be peeling off or whatnot, then they need to be aware that the efficacy is significantly decreased and get a new one on. So that's the basics for the patch. And then the NuvaRing, basically they just need to get it up in their vagina. It doesn't really matter where in their vagina it is, as long as it's in there, it will be releasing the estrogen and progesterone. And you can teach them how to put it in the office, and then oftentimes they're one that tends to give out free samples. So you might even be able to get them started in the office and then send them home with their prescription. So they would leave it in for 3 weeks. So you change it every week with the patch, and then you leave it in for 3 straight weeks with the ring. And then they remove it for a week. And then they can remove it for intercourse, but that really isn't recommended just because we're worried she'll forget to put it back in again. So it would be just fine to have sex with the NuvaRing in still. But you wouldn't want to leave it out for more than 3 hours in any given day. And then every day, if you just want to make sure it's still in there and hasn't fallen out, that would be the smart way to go about it. Okay, so progestin-only methods, no estrogen. We have 4 options. there's progestin-only pills, fondly known as the mini pill. And then there's Depo-Provera, which is an IM shot. Then there's Nexplanon implants and the Mirena and Skyla IUDs. So progestin-only pills, or the mini pill, this is most commonly used for women who are postpartum, who love to take the pill as their main form of birth control and really don't want to try anything but a pill. Then they get the mini pill. So it's a lower dose of estrogen, there's not any estrogen in it, lower dose of progestin, and then no estrogen in it. There's about 4 or 5 different ones on the market in the area, but they're basically all the exact same thing as far as ingredient, which progesterone's being used and what the dose of that progesterone is. Okay, so it's going to thicken cervical mucus. We know that progesterone does that, right? And then ideally it's still keeping you from not ovulating, which if a woman is breastfeeding, then it's like we're doubling up on that. Both prolactin as well as the progestin in her mini pill are keeping her from growing a follicle. And this is one where it's really, really, really important that she's really punctual with her dosing, because we need to keep the cervical mucus thick. So it's all the more important with this one that we're keeping the cervical mucus thick, because the follicle piece doesn't work as well. And then when we're first starting, she should use backup for at least 48 hours, and that 48 hours piece is linked with how long it takes for her cervical mucus to start to really thicken up well enough. And it's fine to use with breastfeeding. And then since it's a progestin, when we think about the profiles for estrogen versus progesterone, estrogen is our cycle control, right? So since we're not giving estrogen, we're more likely to have irregular bleeding and spotting, which we'll find is true of all these progestin-only methods. So next up is the Depo shot, or Depo-Provera. Highly effective. This is a very high dose of progesterone. This is really the only one that comes with doozy side effects of all of the options we're talking about today. So it's working like the other methods. It's thickening cervical mucus and preventing ovulation. Side effects include irregular bleeding. We're not surprised by that. Because the dose is so high, a lot of women end up not having a period. And then because the dose is so high, again, that increased appetite that comes with progesterone, then we also have the weight gain piece. And sometimes depression can come along with that as well, and then a decrease in bone density, which is something to be aware of, especially if you're working with younger women. And this is the only method that has a high link with really delaying return to fertility. So the average amount of time for a woman to really start cycling again after getting off of Depo, if she's been on it for a while, is 18 months. So this isn't true for anything else we're talking about. Depo is a really high dose of progesterone, 18 months to return to fertility once you're done taking it. One of the advantages, I think, about adolescents, where whatever their dynamic is at home, they're scared to have a pack of pills lying around. The NuvaRing tends to be something that they prefer for that reason too, of not having something that's easy to find, because they just keep the ring in for a whole month, right? But this is nice because they just have to go into the office, the doctor's office, and get their shot, and then there isn't any evidence for people to find at home. Obviously, we're not encouraging people to not have honest communication with their families, but just thinking of how we're supporting her and whatever her needs are. Wherever she's at, this is popular with adolescents for that reason. And then basically the way it works is if when she first gets started, if it's been more than 7 days since her last menstrual period, she should still use a backup for 7 days. So she comes in and she gets about 150 milligrams of depomedroxyprogesterone acetate. So that's the kind of progesterone used. And that's given IM, and then she's good for 3 months. So she comes back every 3 months for the shot. Okay, next up is the Nexplanon. Highly effective. Again, progestin only. Works the same way as all the other ones do. It needs to be inserted by a provider with additional training. It would not take you very long to get additional training once you graduate if you want to do it. We're talking like a 3-4 hour workshop. And then if it's been over 7 days since your last menstrual period, same thing, you do backup for 7 days. Side effects, irregular bleeding, as well as amenorrhea. That's really important to educate on. I think it's a great method, especially for adolescents. I mean, with adolescents who are sexually active, the longer acting and the more highly effective method you can give them, the better. We're pushing that and pushing that with public health, whether it's IUDs or the implant, those being the main ones. If we can get them long-acting, highly effective birth control, it's not a patient population that is ready for a baby. Generally speaking, they're not wanting to get pregnant anytime soon, finishing up school, everything that comes along with that. So to be able to get them highly effective forms where they don't have to remember to take a pill every day. The perfect use for taking a pill every day with adolescents is different. So, but with this one, to really educate on the irregular bleeding, these are gals that might just say, I have to wear a pad every day for 3 months straight. Or I feel like maybe I'm not spotting every day, but I never know when it's going to come on again. So just really educate about that, because that's one of the #1 reasons that women will take it out. So ideally, if we're going to give them a long-acting form of birth control, Public Health Resource Savings says, let's make sure they know what they're getting so that they don't plan on taking it out as soon as we put it in. Okay, unlike the NuvaRing, where the hormone levels are just the same as if you were taking a pill, the Mirena and the Skyla IUD both are primarily just giving off progestin locally. So there's a very tiny amount that gets to the rest of their system, but it's almost all just absorbed locally. And the main way it works is by thickening cervical mucus. So far with progesterone, we've had methods that are circulating throughout the woman's body, which means it can get to her hypothalamus and have her pituitary gland get the message not to be releasing FSH and LH, right? But for the Mirena and the Skyla, since there's so little hormones circulating throughout the body, it's really just working by thickening cervical mucus. So there's been studies done with the Mirena where they've gone up into women's fallopian tubes and they've been able to harvest a handful of eggs from when they've had the Mirena, because it's also slowing down the travel, like we said with normal hormonal contraception, like oral pills. How it'll slow down the route from your fallopian tube. This is doing the same thing, so eggs are collecting in the fallopian tube that are just never quite making it out. But it's working because sperm isn't getting up into the uterus to be able to get to it anyway due to the thickened cervical mucus. So I describe it as like a really thick plug that sperm just can't swim through. So for that reason, they would be at an increased risk if they were to get pregnant for having an ectopic pregnancy. Now, overall, you're going to have a lot more women with ectopic pregnancies who don't have IUDs, simply because those women are just a lot more likely to get pregnant. This is very, very effective, over 99% effective. But in the event that she would get pregnant, it would be a higher percentage chance that it could be ectopic, due to the slowed route for the egg. Okay, so we have irregular bleeding and spotting, and that's still common for the first 6 months especially. But I generally will tell women that the first 3 months are, we're expecting some irregular spotting wherever the length of our endometrial lining is. It's going to thin out because of the progestin. So it'll get thinner and thinner, and then it will kind of find its normal. So we might have some irregular spotting for that first month that might kind of continue into the first 2-3 months. And then whatever you have at 3 months will probably be what you have ongoing. And then whatever's at 6 months will probably be what you have until it's time to take the Mirena or the Skyla out. With the Mirena, it is a little bit higher level of hormone. I mean, overall, it's still a very, very low amount. But because it's a little bit higher, women are a lot more likely to end up without a period. I think the packaging says 25%, but I see much higher than that in practice. that end up without a period. Whereas the Skyla, since it's not as much hormone, it's about a third to a half the hormone that the Mirena has, those women aren't quite so thinned out, their endometriums aren't quite so thinned out that they just stop having a period. And making sure that women know that that's a possibility. Some women love having a period every month. It makes them feel like everything's going fine, and it's also reassurance that they're not pregnant. So some women love the idea of no periods, and other women would hate that. So making sure that you're knowing what she's wanting and that she's okay with it, with the possibility of not having a period, is important. So generally speaking, overall, women are going to lose less blood, but they might have more days of spotting. So it might be a little bit more irregular, but they'll be lighter days. So more days of spotting, but overall less blood loss. The Mirena has also been approved as treatment for heavy periods because she'll lose less blood overall, and possibly not have a period at all. So if women are more likely to still kind of want a period, then you could go with the Skyla. The Skyla is a little bit smaller. They basically made it to appeal to women who haven't been pregnant before. So it's a little bit smaller of a device, and then a smaller insert or tube as well. Though, I mean, if what you're looking for is long-term birth control, the Mirena is absolutely not contraindicated for women who haven't had children and for younger women. So I wouldn't just assume that you need to go the Skyla route, because the Mirena will get her an extra 2 years. So let's see here. Yep, and then we're going to use backup for 7 days again once we have it in. All right. So let's just talk about the Paragard so long as we're talking about IUDs. So this is our non-hormonal method. This is copper. In the presence of copper, sperm doesn't know where to go. So we know that the egg likes to call to the sperm. So you have more sperm ending up on one side of the fallopian tube than on the other side of the fallopian tube because the egg is calling to the sperm. But in the presence of copper, sperm get confused and have no idea where they're swimming. And it also cuts their heads off. So you have the head of the sperm and then the tail. It decapitates sperm. So this is spermicidal. So sperm and copper do not mix well. It's effective, this should say 10 years. Depends on what country you're talking, but the Paragard in the US with the FDA is 10 years. Sorry about that. I was using this for a presentation for something else earlier. Okay, so effective for 10 years. And then the biggest thing to know about the Paragard is that while it's not impacting her frequency of her cycle, so you don't have the irregular bleeding or whatnot that you would expect with a progestin-only method, it does give women heavier periods and crampier periods. So usually if a woman didn't have cramps or didn't have a particularly heavy cycle beforehand, she probably won't notice much of a difference if she starts with the Paragard. Maybe the first cycle or two might be heavier or crampier and then it's fine. But if she has heavy periods or crampy periods, then you can expect that it's going to get worse with the Paragard. So that piece really needs to be involved in counseling. And no backup method is required. So as soon as it's in, you're good to go. Paragard is even approved up to 5 days post-coitus for emergency contraceptives. So as soon as it's there, it starts killing sperm. And then while none of our IUD methods have, like all of them are essentially preventing sperm from meeting egg as far as their primary action goes, we do know, while we don't understand it very well, we do know that there's something about having something in your uterus that makes it more of an irritable environment and harder for an egg to implant. So like copper is working at killing sperm so it never finds an egg, and the Mirena and Skyla are working by thickening that cervical mucus so much that the sperm can't get up there anyway, can never get into the uterus, much less the fallopian tubes. So that's the main way that they're working. But in the event that a sperm should get past all of that and find an egg, we do know that for both kinds, it would be a little bit harder for that egg to implant, which depending on what kind of values you have for the woman who's coming into your office, that's an important part of counseling as well. I think one example of that is camels. If they go across the desert in Saudi Arabia, then oftentimes They'll put like rocks in their uteruses, because if you're going to go on a long journey, it would be bad for the camel to be pregnant. So we know that's been done for years and years and years. There's something about having something in your uterus that makes it a more irritable environment. So, some more things to consider with IUDs. It's immediately reversible. As soon as you take it out, they can get pregnant again whenever their next ovulation cycle would come. So we haven't interfered with the cycle that way. And the same goes for the Mirena and the Scylla. While we don't see the effects of estrogen and progesterone changing, the endometrial lining to cycle each month, the egg is still busy making and growing an egg every month. So that cyclic nature of how the ovaries are functioning with the pituitary gland, none of that has been affected at all. So their fertility is immediately reversible. It's very cost effective with long-term placement. It's a lot of money up front, but if you're going to use it the whole time that it's available, it's basically your cheapest option. Again, it's a lot of money up front, but if you really do use it for all it's worth, it really is cost effective. You can use any of those methods while breastfeeding. The Paragard can be put in immediately postpartum. You could put it in as soon as the placenta comes out. That's an option. It's a little more likely to be expulsed that way, but that is an option, especially if you're not sure if you're going to be able to see her back anytime soon. And then the Mirena is fine to put in at the 6-week postpartum visit. With breastfeeding moms, there is a higher risk of expulsion and perforation, but that's just a risk in general that would be discussed within the context of IUD counseling. The expulsion piece is if you can just advise people to check their strings every month just to make sure they're still there, then they have that reassurance that the IUD hasn't fallen out, so it's still working for them. And then perforation happens about 1 in 1,000. And the average time for us to figure it out is a year after we put it in. So we're not really sure, did it happen at the time of placement that we perforated her uterus, or did it slowly embed its way in and out? We're not really sure. But we do know the average time to find it is a year later, and it happens very rarely. Precautions, you wouldn't want to put in an IUD if somebody had, say, gonorrhea or chlamydia at the time of placement, because you would be putting it right up into her endometrium, right? Which would put her at risk for endometritis. So if she doesn't have any symptoms, it's fine for you to just check for gonorrhea and chlamydia in the office and still put it in. You don't need to wait for the results. And then if it comes back positive, then you can just treat her on the spot. But if she doesn't have any signs of PID, then it's fine to just keep it in and keep going. Precautions, a uterine anomaly. It's good to know even just which direction her uterus is facing. That can affect where you put the tenaculum, and thinking about where you're guiding the IUD as you're putting it in. Any kind of unexplained vaginal bleeding, again, we don't want to put in anything that can affect her vaginal bleeding if we don't know why she's bleeding irregularly in the first place. So mostly thinking about like endometrial cancer in that case. And that monthly string check is also a check for perforation. So if she can't find her strings, is it because it fell out? Is it because it wandered through her uterus? Over 90% of the time, it's just that the strings are kind of tucked up in the cervix and she can't find them. And if you can't find them, just send her for an ultrasound and then we can go from there. Either they'll find that it's in place, they'll find that it's gone wandering, or they won't be able to find it, in which case we'll assume it fell out and she didn't notice. So signs to watch for, so late period, abdominal pain, infection, change in the length of strings, though honestly I think it's better to just say, can you find them or can you not find them, and not make it too complicated for them. So all of those things would be pieces to keep in mind. We're expecting some changes in her period, but just as a heads up there. Alright, I think that's set for IUD considerations. So there's plenty more we could talk about as far as contraception goes, but I think that's a good overview to get you going. And your books this week are fantastic, and I think you'll find the assignments really helpful too to think about counseling. And probably all of you have already been able to seek some contraception counseling at your sites. So study up hard this week, because of all the pieces in primary care, this is what you will be doing the most in your future practice. So have fun. I just love how contraception counseling is a great way for you to be instilling information and then giving her the power to pick what's best for her. So, all right, have a great week, everyone. Feel free to email me with questions.